when an oncologist tells you, I hope not, or one of your relatives or anyone, that the patient can eat anything, which is what I was told back in the day and what I am tired of hearing some oncologists say to many of my patients, that nutrition is not important. Yes, it is important, that they should not become malnourished, but know that it is actually nonsense, that not taking this or that is really silly. Well, you can always turn to 2009, to this information, to these slides, to these studies, and say, at least consider it, right? It can really help. There will also be, as we will see later, functional foods that can be included in each of those steps or seals. Then I will indeed insist on this second adaptation of the cancer seals that was made in 2011. It was already in the year 2000 that they went from being 6 seals to these you see here, which are 12. And the important thing is that for each of them, specific chemotherapy drugs have been developed for resistance to cell death, for the deregulation of a cellular energy metabolism, which is related to the mitochondria. One of those tools, which is the one up there, would be the ketogenic diet for inflammation, as we were saying, to avoid immune destruction. Just as there are chemotherapy drugs that are applied to each of those distinctive seals, there will also be, as seen later, functional foods that can be included in each of those steps or seals. This slide is very important. Well, not this one, the one we will see after the cancer seals. Because oncologists are very familiar with this concept, and they are very familiar because, as I tell you, almost all the drugs that are developed try to fit into some of these. When an oncologist tells you, I hope not, or one of your relatives or anyone, that the patient can eat anything, which is what I was told back in the day, and what I am tired of hearing some oncologists say to many of my patients, that nutrition is not important, that yes, it is important for them not to become malnourished, but that no, that in reality it is nonsense, that taking this or that is really silly. Well, you can always refer to this information, these slides, these studies, and say, at least consider it, right, that it can really help. That's why studies and evidence are very important. A little bit this approach, because it's about speaking the professional's language. Well, as I was saying, the role of the endocrinologist, the specialist in endocrinology and nutrition in the hospital, in the cancer patient is also very important, because a nutritional risk assessment must be made, which is fundamental. Depending on the types of cancers, risk of malnutrition is greater or lesser. As you can imagine, it is higher. More it involves the digestive system. Evidently, it is higher in those cancers of the head and neck, pharynx, larynx, abdominal, or hematology. Because in cases of hematological cancers, a bone marrow transplant usually has to be done, and that basically involves wiping out the patient's entire immunity and subjecting them to parenteral nutrition that must be managed by a professional. So, always try to seek multidisciplinary teams that involve a specialist in endocrinology and nutrition, especially for those. And I am already talking about the moment when the patient is undergoing treatment, especially in those cancers with a high nutritional risk. And also, depending on the treatment that this patient is undergoing, the nutritional risk will be lower or higher, and it is higher again in those treatments that involve the patient not being able to nourish themselves, such as head and neck radiotherapy, total body irradiation, or oncological surgery. In fact, in nutrition services, what is done most of the time is to place a gastrostomy, which means that while the patient is, for example, undergoing radiotherapy or is recently operated on for laryngeal cancer, a tube is placed directly into the stomach and enteral nutrition is provided. We can later discuss whether enteral nutrition preparations are better or worse, and indeed there is much to talk about, but the fact is that what is important is for the patient to be nourished, and for that, the specialist in endocrinology or the hospital nutritionist plays a fundamental role. I'm not going to go into this, as we discussed it more in the course, in the cancer chapter, regarding what the assessments are, because it is very important to discern. It's not just about being thinner or less thin, We need to assess the speed of weight loss in this patient, whether they have lost fat or muscle, some nutritional parameters. And for that, there are many scales that are used and that we study in the cancer chapter of the expert course. Malnutrition is defined as the loss of fat or weight in a patient over a certain period, occurring in 40 to 80% of cancer patients at some point during the illness. It is important to know that up to 90% of patients with advanced neoplasms experience a weight loss of at least 10% of their usual weight. And it is also very important, at least from my point of view, to try to meet those needs or to try to remedy that malnutrition with the type of food and the knowledge we are trying to convey to you, so that you don't experience what happened to me, which is that since I wasn't eating anything, I was feeding my cancer rapidly with sugar. Well, as we have said, the causes of malnutrition can be caused by the tumor itself, by digestive disorders, by functional alterations related to the patient, because, as you know, they lose their appetite, which is called anorexia. Cachexia is extreme weight loss, and there are also evident psychological factors such as depression, anxiety, loneliness, decreased intake due to treatment, surgery, or radiotherapy. I am going to address the part, this is just so you know, that all the causes and all the surgeries and procedures are seriously compromising the patient's nutrition. Chemotherapy, enteritis, which I suppose Amar will discuss in relation to dysbiosis, because practically all patients undergoing abdominal surgery or radiotherapy will experience enteritis and an alteration of the microbiota, and it is essential to address that. We are going to the part about functional foods. Well, it is important for you to know that there are several types of malnutrition, which can be caloric or both caloric and protein. And oncological patients usually have mixed malnutrition, caloric and protein. And one of the things that happens here is that it alters the healing mechanisms and increases the risk of surgical complications such as suture dehiscence. So my advice is that at all times, you request or have the intervention of a professional before, during, and after surgery, as I have said, especially if they are tumors of the digestive system, because the nutritional status prior to a surgery, for example, of the intestine, is fundamental if we want to avoid post-operative complications, for example, regarding the adherence of the sutures, that is to prevent the site of the intestine from breaking, because the patient, tumoral cachexia, as we have said, can vary up to 80%, and it implies a lower therapeutic response. In fact, many oncologists do not want to repeat a cycle of chemotherapy or radiotherapy if the patient is not sufficiently well nourished. And as I was saying, it can be with loss of fat mass or without loss of fat mass. Usually it does involve it. But above all, what concerns us the most and what leads to a worse prognosis is the loss of muscle, called sarcopenia, which causes functional deterioration and a worse prognosis. And the goals are basically to improve the quality of life and certainly to enhance the patient's prognosis. So the guidelines will be aimed not only at preventing and correcting nutritional deficiencies and avoiding weight loss, but also at preventing the deterioration of the immune system, as I have said, which is essential to fight against the disease and to allow the oncology specialists to continue, if they are being given, with the corresponding treatment cycles.